essentially left holding the bag for all the downstream ramifications, while others increased their profit margin. The Community Health Center program is one of the most widely bipartisan supported healthcare programs in the country. Why?
15 seconds.
Because it works. Community health centers consistently produce high quality outcomes and save the healthcare system money. The 340B program has served as a cornerstone of these efforts for 30 years. The program is now needlessly being placed at risk. We ask for your assistance in providing a legislative solution to allow community health centers to continue delivering on our mission to ensure that everyone has access to high quality health care. I would like to turn over the remaining time to Derek Peel. Thank you very much.
Okay. Matthew, thank you. Actually, you didn't have any more remaining time, but you did use a few minutes of Derek's time, but Derek is up, and Derek, you still have 3 minutes. So
thank you. That was pretty good for me, though.
Can you hear me okay?
Yes, thank you.
Okay. Well, thank you, Mr. Chairman and committee members. We greatly appreciate the time we've been given today. My name is Derek Peel, and I'm the Executive Director of Pharmacy Services at Salina Family Healthcare Center. We are a federally qualified health center that serves Salina and the surrounding area. The fundamental issue around 340B from the perspective of health centers like us is discriminatory contracting practices, primarily by PBMs. Nothing currently stops PBMs from redirecting to themselves the funds that since 1992 have been meant to help safety net pharmacies, health centers, and their patients. They do this through two mechanisms, either kicking safety net pharmacies out of their networks entirely or forcing them into contracts that reduce their reimbursement, which transfers the benefit of the 340B program to the PBM's bottom line. The expectation is for this practice to not only continue, but to increase. This is due in part because of a tug of war between PBMs and drug manufacturers, with safety net clinics and their patients caught in the middle. To this point, our safety net pharmacy has been forced into 3 contracts that lowered our reimbursement based solely on our participation in the 340B program. In order for our patients that have insurance companies using these 3 PBMs to continue receiving their medications from us, we had no choice but to sign these take it or leave it contracts. Our bill that Denise just introduced will stop discriminatory contracting based on 340B. It will give you the opportunity to join multiple states in putting an end to for-profit PBMs exploiting the 340B program for their own gain at the expense of 340B safety net providers like us, and most importantly, our patients who are also your constituents. With that, we thank you again and ask for your support of our bill.
Derek, thank you for your presentation. Brian Williams, President and CEO of Labette Health.
Good morning, Mr. Chairman. Good morning, committee members. Thank you. I'd like to also introduce, I have Tracy Gilmore on the call with me. She's a pharmacist and our 340B manager, and so she can answer any of your technical questions. I agree with everything that's been said. For context, I'm speaking to you from Parsons, Kansas. I am the CEO of Labette Health. We're licensed for 99 beds. We're an acute care hospital. We're a level 3 trauma center, and we employ approximately 860 employees. I agree with everything that's been said. The 340B program is so critical to all of your constituents, this entire state, and the 124 hospitals, of which I believe 86 or 87 participate. The entire state, our entire country's suffered tremendous loss of revenue, increased expenses, and the situation with COVID-19 is exacerbated already our austere resources that we have in small rural communities. What we need and what we ask is really for the opportunity to have stable and predictable revenue streams. The 340B program has been around for a number of years. It's had bipartisan support at the national and state level. Publicly traded companies right now are trading at extreme multiples. Price earning ratios are extremely high, and that is wonderful for our country and wonderful for stockholders. However, it comes at the expense of vulnerable patients, vulnerable pharmacies, vulnerable rural hospitals. So, the main thing I think that we ask you to do is help us, limit the pharmacy benefit managers from their opportunity to really dig into revenues that we need to help our patients get better. I've provided you 2 pages of testimony. I just draw really to the next to the last paragraph and put it in real terms. Between September and December, we've lost $583,000 of revenue or 340B benefit. Now that all of these actions are taking effect at the national level and the state level, January will probably suffer a loss of $400,000 in 1 month. If you annualize that, that's over $4 million of benefit. We have so many hospitals that have closed in this country and this state. I know that's not what any of us want. So thank you so much for your attention. And if there's any questions I can answer, I'd like to.
Brian, thank you. Todd Wilhart, CEO of Community Healthcare Systems. Thank you. Welcome and thank you.
Okay. Good morning, Mr. Chairman and fellow committee members. Again, my name is Todd Willard. I'm the president and CEO of Community Healthcare System in Northeast Kansas. And I also want to thank you for the opportunity to provide testimony here today on the importance of the 340B program to our hospitals, to our communities, to our community pharmacies, and most importantly, to our patients. As was mentioned before, the 340B program has been around now for almost 30 years and has helped support everything that I just listed above. But last fall, the major pharmaceutical companies decided to almost, I would say, declare war on hospitals in the 340B program. For example, in last fall, Eli Lilly and AstraZeneca said that unilaterally said that they would no longer offer 340B pricing to covered entities at contract pharmacies. At the same time, Sanofi, Novartis, and Merck also started restricting access to 340B drugs. At the same time that they're trying to eliminate the 340B discounts, they are continuing to offer rebates to pharmaceutical or to pharmacy benefit managers or PBMs. These same PBMs then adopt payment discrimination and restrict patient access to local pharmacies and require patients to use preferred or mail order pharmacies, which significantly impacts the relationship between the patient and the local pharmacy, and particularly in our rural areas, which we serve. I should have mentioned that Community Healthcare System, we have about 450 employees. We serve an extremely rural area of Northeast Kansas. We also have 6 full-time medical clinics in small rural communities, and we are in 4 different counties. So what's the impact of what the drug manufacturers are doing to the patients? So that is probably one of the, how much, 1 minute left? That is probably the most alarming aspect of this whole thing. So I'll just give you one good example. In January, all major manufacturers of insulin eliminated their products for the contract pharmacies in the 340B program. In the past, a diabetic patient would have been able to get a insulin prescription drug for about $16 a month. Now that cost is going to be $600 a month for that patient. We know what the patient's going to do. They're going to cut their insulin doses and they're going to make other choices. Our doctors are asking the question, what can we do? So again, this really does impact patients. It impacts hospitals. It impacts our local pharmacies who really rely on the 340B program to be profitable. So again, I want to thank you for your time. I want to thank you for your support. And please do what you can to help support our rural hospitals, our patients, and our rural pharmacies. Thank you.
Todd, thank you for your presentation. Committee members, I will direct your attention to the written only testimony. We have Daniel Kreitz, Community Health Center, Southeast Kansas, Amy Falk, CEO, Health Partnership Clinic, Joe Dunn, Association of Community Centers, and Robin Covington, CEO, Heartland Community Health Center. This was just to reassure everybody, this was just wasn't an informational hearing on any type of bill that we are proposing. This was just supposed to be information on the 340B drug pricing program. So with that, we'll open the floor for questions. Senator Thompson.
Yeah, I'm curious. I'd be very interested to hear, Mr. Chairman, from the PBMs and the pharmacies to see their side, because obviously there has to be some cost shifting to, if you provide a discount for certain people, they have to shift the cost onto somebody else. I'd be very interested in seeing, what the dynamic is in all this, or maybe somebody here could answer that question for me.
Yeah, because this was just an informational presentation on the 340B program. There aren't proponents, opponents, or neutral testimony. So we do not have a bill, and this isn't a bill hearing. So those people, I don't believe there's anybody here for any representing PBMs or pharmacies that could give us any answers. If we do have a hearing on a bill, we'll definitely make sure that all parties are present so we can get both sides of what's going on. Senator Petty.
Thank you, Mr. Chairman. We did have a bill request this morning introduced for this very issue, so I hope we do have a hearing. This is a question, actually probably anybody could ask it, but I'll address it to Brian Williams. And I'm wondering about, there is mentioned in his testimony that there was a House Bill 2631 that was introduced last year. Did that just end up not going anywhere because of the time crunch? I see Stuart. Okay, go ahead. Denise.
Yes, we had introduced that bill last year, which is the same bill as what we're introducing this year, and it was not able to go out of committee because of the time crunch, and we did not have a hearing.
Thank you, Denise.
Are there any other questions? Senator Stephan.
Thank you, Chairman. I'm just trying to get my head around this whole thing. Is this basically as simple as a prior negotiation agreement falling apart, and as such, the pharmaceutical manufacturers have moved the pricing way up on you? Is that basically it in a nutshell?
I believe Denise wants to answer that. Go ahead, Denise.
I hope I will answer it, and let me know if I don't provide all that you need. But this is a federally mandated program where the pharmaceutical companies are required to provide discounts on their medications when they sell them to what they're called covered entities. So federally qualified health centers, lookalike health centers, critical access hospitals, KU Med, for example, are all covered entities. So the discount then, when a pharmacy purchase medication that's out of 340B, they pay a certain amount and then they charge the insurers a certain amount. The difference between the two goes into the pocket of the pharmacy owners, and that's their profit. With the 340B program, you also have a discounted price that the three covered entities purchase the pharmaceutical for, and then they charge the insurers. And the difference is reinvested back into the health centers and into the hospitals to provide more services, reach more patients, and cover some of the services that wouldn't ordinarily be covered by insurance. And so the difference is, do you want the money to go into the pockets of the pharmacies and the PBM specifically? That's what we're most concerned about. Or do you want the money to stay in Kansas and be able to use to support Kansans, especially the most vulnerable? Does that help?
Follow-up question real quick. How long is this program? When did it start?
It started in 1992, and it has been going along, quite well since then. I do have to say, about 4 years ago, we started to hear a little bit of rumblings from the PBMs, and they were starting to want to take some of that difference, the discount, or this, we call it the savings, between what the purchase price is and what the reimbursement is. And they started in Ohio. There was a lot of public outcry, so it was squashed. But since then, They have gained momentum, and what was a snowball is now becoming an avalanche. And if left unchecked, we're going to lose the 340B program in totality.
I just want to reiterate that unfortunately there are no opponents or neutrals here. This was supposed to be an informational hearing for the committee on what the 340B program was, not to advocate one side or the other. I appreciate the answers and the questions, but if we could get back to what exactly is the 340B program. Any more questions on that? Senator Thompson?
I think a couple senators had hands up before me, but I'll go ahead very quickly. What medications are affected by this program? Is it a very narrow scope, or is it pretty much all? Because I know those pharmacy benefit managers, they manage some of the medication I take, and just kind of curious, the dynamic there with the 340B.
Mr. Chairman, this is Brian Williams. Tracy, are you on the call? Could you maybe answer? It's a limited number of drugs.
So in order to participate with the Medicaid program, manufacturers have to agree to also provide a 340B discount. So it is a wide range of medications. And depending on the contract that you have, that might be a narrower scope, but almost every medication is included in the 340B program or can be included.
All right, thank you. Thank you, Mr. Chair.
Senator Gossage?
My question is to anyone who's already testified or given us information, and that is, if this is a federal program, I'm interested in how anyone in the Capitol may help with this situation.
Senator, this is Brian Williams. I know Senator Moran and his entire staff has worked tirelessly over the last year on COVID and provider relief and CARES Act. And it's been brought to their attention. And I believe there's bipartisan support to work on fixing this at the national level. There's been court cases filed at the national level. I believe there's some cases going before the United States Supreme Court. This is a federal program that was started by Health Resources and Services Administration, HRSA. Like sometimes there's unintended consequences with all legislation, and there's probably some windows and things that need to be better defined. I think the angst that you may feel from all of us, I think Todd used the word unilateral. It's not really a contract. It's a law and a program that was specifically put in place to help rural healthcare providers stretch scarce federal resources in this country. And at a time of a national health emergency during a global pandemic, probably not the best time for publicly traded companies driven predominantly by profit to really assault hospitals and healthcare providers when they're already vulnerable, while our legislators are working very hard to prop up our economy and prop up the health systems. I think that's the biggest angst. I think all of us would be willing to address and admit that there's probably some things that we could improve on the program. We all want to be compliant and we want to do things correctly, but it has national attention in both the House and the Senate. And eventually it will be resolved. I worry at how many hospitals will close if it's solved in our court system. It needs to be solved in the legislative system.
I would like to add to that, that most of this is a federal issue. However, something that the state is very integral in is PBM discriminatory pricing, and the states can act to prevent PBMs from coming into our state and providing discriminatory pricing.
Thank you. Senator Petty?
Thank you, Mr. Chairman. Denise, you did mention earlier that this was a presentation before the Bob Bethel Can-Care Oversight Committee. Would you remind me or the committee, did we take a position?
Yes, the committee recommended that both of the Health committees would consider this and provide an opportunity for testimony.
Do we have any further questions on this? Seeing none, we will close the presentation on the 340B drug pricing, and now we will open the presentation on oral health in Kansas. First up, we have Christy Wells, Policy Director of Oral Health in Kansas. Christy, welcome to the committee.
Good morning, Chairman Hildebrand and members of the committee. My name is Christy Wells, and I'm the Policy Director at Oral Health Kansas. We are the state consumer advocacy organization dedicated to improving the oral health of Kansas. Our focus at Oral Health Kansas is on dental public health, and I put in my testimony quite a bit of detail on what that includes, but really it's just the idea of looking at, the community as a whole versus individual treatment plans like you would see at a traditional dental office. So one of the components of dental public health is oral health surveillance, which is the local and up-to-date data that we have on the community oral health status. So this really helps to identify gaps in the current oral health programs, but also show the improvements made through policy and education. And as important as oral health data is, it's often very difficult to find because it's not something that is, tracked each year. Really, we don't have a great way yet in Kansas to do that. But that makes us even more excited to share with you today a new 2021 Kansas Oral Health Report Card. And it looks like this. I wasn't sure if I'd be able to share my screen, but it should be in your testimony. So hopefully you guys have that. And overall, our state received a C grade. And so that shows that, we've made quite a bit of progress in oral health, but we also have some room for improvement. And there are 13 oral health indicators on that report card, and each received a grade comparing our state percentage to the national percentage. And all of those percentages can be found on that second page of the report card. So the disadvantage of this grading scale of giving, a letter grade is that it hides areas of improvement in our positive grade. So if you look at indicator number 13, we did receive an A on that, but it's showing that only 40% of the needs were met in dental health provider shortage areas. So we still have, 60% of those needs that are not being met that we could still be working on. And I won't talk through each of the indicators for the sake of time, but I invite you to look over this list when you have time. If you have questions, please send them to us. But I would like to draw your attention to indicators 1 through 3, which talk about children enrolled in Medicaid and their ability to access a preventive dental care visit. If you look at the first one, you can see that that grade is especially low. And I just want to share that Oral Health Kansas uses data like this to develop our policy and education priorities. So we currently are working to address this gap in access to care for ages 1 through 2 through educational programs for pregnant women and families to teach them the importance of age 1 dental visits and how to take care of their children's teeth from birth. And for each of the educational programs, there are policy solutions that can also help to address all of the gaps in these indicators that are listed on this report card. And we look forward to working with the committee to address those gaps. Thank you for your time this morning and the opportunity to speak with you about oral health today.
Thank you, Christy. Kevin Robertson, next up with he's the Executive Director of Kansas Dental Association. Welcome, Kevin.
Thank you, Mr. Chairman, members of the committee. As mentioned, I'm Kevin Robertson, Executive Director of the Kansas Dental Association, and pleased to be with you live and in person today. It's my job to talk about 3 things with oral health. The Kansas Dental Association has been a founding member and participating member of Oral Health Kansas for many years. So we've worked on things together and then obviously separately, but all regarding to access to care with Kansans around the state. First of all, I want to talk a little bit about CanCare, everybody's favorite subject, I'm sure, but for the first time since 2001, the legislature back in 2019 and then again last year provided a $3 million increase each of those 2 years. That's 1.2 million state money and then about 1.8 million with the match into dental rates. And so over the last couple years, working with the state, we've increased many of the dental procedures about 10 to 12%. And that is very helpful, and we do appreciate that. Now, the question that I wish I could answer for you then is that increasing access to care. This isn't the best year to ask that question, to be honest with you. I do know that we've had about 8 pediatric dentists that have become Medicaid providers over this last year, which is fantastic. And I can tell you that we'll be continuing to monitor that. And I want to talk a little bit there, digress a little bit about COVID and dental offices just for a minute so you get an idea. Right now, dental offices are operating at about 80 to 85% of what would be the normal for them. We see about 10 to 15%, well, maybe 5 to 15% of patients that have still not returned to dental offices. At this point, as far as vaccines, obviously that's been a big issue. We've had most dentists, if not all dentists, have at least gotten their first vaccine. So let me move on quickly because I know I'm pressed for time. I want to talk a little bit about our KIND, our Kansas Initiative for New Dentist Scholarship Program. That's a program that's privately funded, where a partner is Delta Dental of Kansas, and we appreciate their partnership. And since 2013, we've provided scholarships to 18 students and or loan forgiveness grants to dentists to get them out into rural areas. There's a map on the back of this that'll show you my testimony, hopefully you've got it somewhere, that will show you kind of where we've been able to place people and continue to do that. And last, probably our most visible program is our foundation's Kansas Mission of Mercy free dental clinic that we've provided around the state for the last 20 years now. $20 million in free care to about 31,000 patients. We were planning to be, like next week, in Wichita. Obviously, again, COVID and restrictions, we've set that out to June, and that we are still working to see if we're going to be able to have that. But that's the plan, and I'll move forward and let the next person go. Thank you.
Thank you, Kyle. Next up, we have Philip Steiner, Analyst for the Kansas Health Institute. Welcome, Philip.
Thank you, Mr. Chairman and committee members. I'll be sharing some findings with you all today from a report that KHI has done with Oral Health Kansas on dental insurance rates in the state. So let me see if, can I share my screen?
You should be able to, yes.
Okay, thank you. All right, can you all see that?
Yes, we can see it. Thank you.
All right, thank you. So this here is the first finding I'd like to share. It's showing dental insurance rates for the state overall. And so you can see that about a third of Kansans, and I should note real quick that this is 2017 data. So this isn't anything post-COVID, but we do think it's probably somewhat similar to health insurance and has stayed fairly stable. Again, up until the point of COVID, we're not sure what happened after. But so about a third of Kansans lack access to dental insurance coverage. That's the top line finding. And then we also split this out by age. And there is apparently a discrepancy in whether or not folks have, or disparity in access to dental insurance coverage by age. So you can see that children are the least likely to not have dental insurance. About 17% of kids have or don't have access to dental insurance. That's primarily because they qualify for CHIP and Medicaid at higher income levels. So more of them have access through those programs, and then also secondarily their parents through their employers. So like working age adults, a little over a third of them do not have access to dental insurance coverage. And older adults or senior adults, 65 or older, are the most likely to not have dental insurance. About half of them do not have coverage, and Medicare does not have a dental benefit. There's also some disparities in dental insurance coverage. Hispanic and race children are about 2 times more likely than non-Hispanic white children to not have dental insurance. Similarly for adults, Hispanic and race adults are about 2 times more likely than non-Hispanic white adults to not have dental insurance. And then lastly, I'll just call your attention to a finding on Medicaid enrollees specifically. A little under a third of Medicaid enrollees are reporting that they do not have access to dental insurance coverage or coverage that pays for dental care. We know that CanCare has a benefit that includes dental insurance coverage for children and adults. I think it's maybe a little bit more limited for adults. And that's somewhat reflected here in this data. You know, a lot of parents are reporting for their children that they do have some coverage that pays for dental care, but about half of adults on the CanCare program are reporting that they don't have any coverage that pays for dental care. We don't have great insight into why this is. The survey didn't ask about that, but it's possible that either they're having trouble accessing the services that they do have offered to them, or they possibly just don't know about the benefits that are available. So there may be some opportunity for outreach or conversation there.
Philip, thank you. Thank you for your presentation. Next up, we have Dean Newton, President and CEO of Delta Dental of Kansas. Welcome, Dean.
Thank you, Mr. Chairman and members of the committee. My name is Dean Newton, President and CEO of Delta Dental of Kansas. A little bit of background. We're a 501c4 social welfare organization set up under federal law to provide benefit to Kansans and the general public, and we take that responsibility very seriously, and we accomplish it in 3 ways to improve oral health. First, we work to ensure that we have affordable dental care, reduced healthcare costs, and exceptional service that meet the needs and the budgets of the greatest number of Kansans. People are 3 to 4 times more likely to go to the dentist with dental insurance, so we try to have affordable dental insurance so they will get to the dentist. 2, we work very hard to get Kansans to the dentist, regularly pushing out messaging about the importance of oral health and contacting our members who don't go to the dentist within a year, as an example, to encourage them to go to the dentist. And 3, we try to increase access to care and improve oral health through affordable premiums, enhanced benefits, and charitable programs to give dental care in rural or underserved areas. In 2020, for example, every single Kansan and Kansas employer that we covered, we refunded their April premiums so they could manage expenses during COVID. Over 2020, we've given more than $7 million to our dentist partners during COVID to help them manage through COVID. And so offices would stay open so your constituents could have access to oral health care. To our knowledge, we're the only insurance company in the United States that has given a 3rd and a 4th dentist relief program during COVID. We offered programs to enhance benefits. So for example, thank you. For example, every child under 12 receives 100% dental benefits at our cost. It's called Right Start for Kids. And we have a lot of programs to increase access to care in rural underserved areas. For example, the KIND program we have in partnership with the Kansas Dental Association, with Kevin Robertson mentioned earlier. We are a sponsor of the Kansas Mission of Mercy. We partner with United Way organizations across the state to give low-income children and families access to oral health care. And we work with a variety of other organizations to ensure that low-income individuals in underserved areas have access to oral care. And finally, our network discounts and cost management programs ensure that we can provide affordable care to Kansans and increase access to care in a budget that meets their needs. With that, I will stand for questions, and I appreciate your time today.
Thank you, Dean. Next up, we have Tanya Dorf-Bruner, Executive Director of Oral Health Kansas. Welcome, Tanya.
Thank you so much, Mr. Chairman. I appreciate the opportunity to be here today. Again, I'm Tanya Dorf-Bruner, Executive Director of Oral Health Kansas. And I really appreciate the committee's interest in holding this briefing today. As you can see, there's a lot to the Kansas oral health community, and we've just kind of scratching the surface, but we're excited to share a lot of details with you. I want to follow up on a couple of issues and then hopefully get to lots of questions. First of all, I want to talk about adult dental benefits in Medicaid. Philip alluded to this a little bit, that there are some benefits in the Medicaid program for adults. And just to reiterate too, what he said is about 17% of Kansas kids lack access to dental care or dental insurance, but that's mostly because the Medicaid program requires coverage for children. So there's a lot of great coverage for kids. Adults don't have that same coverage, and especially in the Medicare program, there is no coverage. The CanCare covers basically what I would call the bare minimum for adults. they cover emergency extractions, which is essentially if somebody has some kind of an emergency, and believe it or not, can often be a life-threatening sort of emergency, people can get an extraction, but there is no coverage for just like a filling that could often prevent an event from getting to that level. And there's no coverage for dentures. So if somebody does lose their teeth and they don't have a way to get dentures and be able to get their smile back, it's really, I think for a lot of us, we think of dental care as kind of a routine thing, and most of us are pretty fortunate to be able to have access to it. But for lots of low-income Kansans, it's pretty much out of reach, and it just doesn't only affect their health; it affects their ability to get and maintain good jobs as well. So it's a real economic issue for us. I want to share that we've been talking for a few months with the CanCare Oversight Committee, the Bob Bethel Committee, about a study that we've started working on with the American Dental Association's Health Policy Institute. They're an organization or part of the ADA that generates and disseminates research for providers, for lawmakers. I'm certain that probably says 1 minute. I can't tell. Thank you. And so what we're working on is a study that would calculate not only what it would cost to add a comprehensive adult benefit in Medicaid, but also what the offsets would be. What kind of cost avoidance would we have by helping people maintain their diabetes, for example, and not go to emergency rooms? So we are working with them on that. We hope to be able to have some data in mid-March, and so we'd love to be able to come back and talk to the committee by the time that's available. So another quick thing is we are working with legislative or with the revisor's office to introduce a bill. We introduced a bill last year called the Kansas Oral Health Improvement Act. It was a victim of COVID and didn't get a hearing before the legislature had to adjourn, but we're working on hopefully introducing that again here shortly. And then just to wrap up, I just want to thank you again for this opportunity. We've covered so many things. There's clearly a lot more room for research and a lot more data that needs to be gathered and a lot more information we all need to share. So hopefully today is just a jump start to a whole lot more conversations. And I'll stop there and hopefully we get to have a lot of time for questions. Thank you.
Tanya, for your presentation. And at this time, committee, we will open up for questions. I do have one for Philip Steiner, Kansas Health Institute. You had mentioned that roughly 1/3 of kids, although they have dental through CanCare, there are no providers for them to visit. Is that correct? Did I hear you correct on that?
Well, so we don't. It's about 1/3 of Kansans on CanCare, and it's only about 14% of kids. And we don't have great reasons, or we don't have a lot of insight into why these folks responded on this survey saying they didn't have access to dental benefits or care, any insurance that paid for dental care. But we just know that they had CanCare and they responded like this on the survey. So we speculated that it's possible that it's because they don't have access or that they don't understand their benefit or know how to use it, so that they chose to respond this way, that they didn't have any coverage that paid for dental care.
Philip, would that be something that you guys could dive into just a little bit deeper to find out why? Is that a possibility?
Certainly. There's not a lot of great data, but we could look into it, see if there's something we can put out.
Okay, thank you. Senator Gossage.
This is really just a comment for Tanya, and that is that, yes, Medicare does not offer dental services, but most seniors have an additional Medicare Advantage plan. In fact, we have about 40% of seniors nationwide, and most of them do cover not only dental, but also dentures are included in that. So just thought I would mention, even though we say that about Medicare, I thought that we should mention that. And if I may, Mr. Chair, one more quick question or one more quick comment, and that is, because someone has dental insurance, it doesn't necessarily mean they don't have access to dental care, right? Because we do know there are discount programs offered by Aetna, Cigna, and others that are not considered dental insurance, but they can give a substantial discount on dental services.
Mr. Chair, I can take a stab at answering that, and my colleagues might be able to help as well. That's absolutely correct. But that again is really accessible for folks that have the means to get those plans. To a great extent, we're talking about a lot of folks that are living in poverty or living close to poverty and wouldn't have the ability to buy an extra plan. So I think both things are absolutely true. The dental insurance world is an interesting place, and it's a little different than the medical insurance world. Yeah.
Yes, the dental insurance can be $35 to $40 a month, but a discount plan is $7 to $10. Thank you very much.
Thanks.
Senator Petty.
Thank you, Mr. Chairman. I think maybe Kevin can deal with this. Kevin, you mentioned last year that with the increase and so I know that a big part of the discussion with that whole thing was there's an increase here for provider rates, but the number of providers that are participating isn't increasing. And you mentioned that this past year would not be the best year to look at that, but you did go on to say that we do now have 85% of dentists are up at capacity.
Dentists are at about 80 to 85% of capacity.
So can you share with us what kind of an increase we've seen and participate in?
Well, I can't because I haven't been able to get that information from the state. So we have asked, Oral Health Kansas has asked, and the information we've gotten at this point is that 8 new pediatric dentists have joined the program, which is, there's only 55 pediatric dentists in the entire state. So if we have 8 more, that's really a fantastic number to get that many more pediatric dentists. But as far as, there's always 2 numbers when we talk about providers on CanCare for dentists. There's how many are enrolled, but then there's also how many are participating. So for example, there may be 572 is a number I remember from a couple of years ago that were actually enrolled, but only 370 or something were actually participating, and then on a monthly basis taking patients. So it's the combination of how many are enrolled, but then how many of those are participating and taking patients. So those are things we'll need to dive into the numbers. We're going to need the state's help and the MCOs to help us with that.
Thank you. I do have another question, if that's okay. This would go to Christy, and that's right. Christy, I have to keep shifting back and forth here on the testimony, but because you provided us with the, did you provide us with a report card? Who provided us with the report card? Christy?
Absolutely. I had sent it to the committee assistant, but I can.
It's in the testimony. I just flipped down too fast. So Christy, good to see you. And I know from the past, isn't one of the issues, I know when we look at this like our rating and the grade F for ages 1 through 2 receiving a preventive dental care visit. Have you done some research into the fact that if parents don't have dental insurance, then it's also less likely that they're going to provide or take their child to the dentist?
Absolutely. I would say that, if you're going to the dentist as an adult, as a pregnant woman, your dentist is educating you on, when your baby is born, you need to be coming back to the dentist 6 months after their first tooth erupts. And if you're not going to the dentist because you don't have dental benefits or you don't have dental insurance, you just don't find out that education unless you're finding it out through maybe your medical provider or the health department. So that is a big reason why we encourage, adult dental benefits in Medicaid. And it's also a big reason we do a lot of education with like home visitors and health departments so that they can help really spread that education until we can get coverage for adults.
Then just as a follow-up, if that's okay, I know that Dean mentioned the Kansas Mission of Mercy, and I'm assuming that fits into when we have had these mega dental days, you know, whether it's in Manhattan or whether it's here in Topeka. And although those provide service, an impact service for a day, in the oral health community, those are not looked at as a replacement for regular and continual attention to oral health?
That's a great question. And I love Oral Health Kansas or Kansas Dental Association to jump in as well. As Kevin Robertson said, since 2004, I think there's been roughly $20 million in oral health care provided by dentists in Kansas to Kansans. And I know since 2015, there's been about 6,300 Kansans that have gone through the program. Those are to meet immediate needs and to improve oral health care. But yes, you're exactly right, Senator. Continued oral health care to maintain it, and that's the messaging we try to get to our members, is you have to have regular checkups and visits to the dentist to ensure that that continues.
Thank you.
You're welcome.
All right, committee, we have time for one more question and a brief answer if we can. Make it brief. Is Dr. Steffen.
Thank you, Chairman. Mr. Robertson, you talked about the difference between dentists that are enrolled and who are participating. Can you give me 2 or 3 reasons why the difference in the enrollees versus participants?
A lot of times someone will enroll, frankly, and they'll be enrolled for a long period of time, but they just get to a point where either they've had frustrations with the program, there might be a recoupment. We always hear stories of why somebody had an issue, didn't get reimbursed, whatever, and then they've chosen not to. Now, technically, they're still enrolled, but they just stopped. So that's one issue. In some cases, someone's business or their dental practice may be full, or they may have gotten to a point where, gee, they've just been overwhelmed with patients in local communities. They've chosen to cut out. A variety of reasons, and I'm sure there's as many reasons as people that are.
You've never investigated that?
Well, we've never surveyed that and had a list of, hey, this many questions where I could say 25% of this. Generally, it is because either the practice is full, rates have gotten so low where they have not determined that that was enough good for the practice.
Medicaid rates have got so low?
Well, again, up until the last 2 years, like I said, we had a 10 to 12% increase in some of the Medicaid rates, but there hadn't been an increase since 2001. So Medicaid rates are a good 50% low and one of the lowest in the country.
Thank you, committee members. And if there is nothing else to come before the committee, Representative or Senator Holscher.
Yes, just very quickly, for the good of the committee, I wanted to let you know I spoke with Johnson County Commissioner Ed Eilert yesterday about the vaccination distribution. Things were much, much smoother yesterday. On Tuesday, a couple of the issues where there were people showing up who weren't in the required age group that just wanted to try to get the vaccine. Some people actually showed up an hour and a half early for their appointment, which caused some long lines. But at this point, there are buses there shuttling people from the parking lot, and there are warming buses there. So again, things were much smoother yesterday.
Thank you very much for that update. Committee, we are adjourned. Thank you.